Today's module is on rotator cuff tear. This commonly involves two of the major rotator cuff muscles, supraspinatus and at times also infraspinatus. This is a very painful condition, and more importantly, it causes a fair amount of weakness, even without pain. When I say rotator cuff tear, I really mean complete tear, the sort of thing that a surgeon likely needs to evaluate. And it's important to make a prompt diagnosis. If diagnosis is delayed, the prognosis from a surgery is often not as good. And when we get to the history and physical examination portion of this module, I'll talk about other treatments if the tear is not complete and how to do a good diagnostic workup to get patients the prompt attention they need. Rotator cuff muscles, there are 4 of them, and I'll show those on the model. And then I'll discuss the ones that are most commonly torn. Supraspinatus, above the spine of the scapula. Infraspinatus, below the spine of the scapula, that's the structure. Teres minor, which is well named because it's kind of minor. And then subscapularis, which we'd have to sort of take the scapula off the rib cage. It's the anterior one, the one in the front between the scapula and the rib cage. Very rarely torn. The most common torn are supraspinatus and infraspinatus. Classically, especially in the younger patient, a complete tear, there's usually trauma, falling from a ski accident, getting clipped in football, impact from a car window in a T-bone collision, that sort of thing. Patients will complain of pretty profound weakness, and you want to, when you're doing your exam, try to sort that out from a nerve injury from, say, the neck area. Sometimes it's hard to sort this out from tendinitis versus tear, and I'll talk about that more. Again, when we go to our exam, we have our model patient here, Jennifer. We would always again do just a brief screening exam of the neck, recognizing that if the rotator cuff muscles are very weak, it can look like cervical radiculopathy. When we do the shoulder exam, typically overhead range of motion is fairly good for the patient if I'm doing it, if it's passive. But if they try to do it, they kind of get about that far and they really can't go any further. Or they can't even get beyond a small amount. We'll talk about why that is. And they'll have difficulty with external rotation or profound weakness with external rotation, so that when I test the external rotators, the patient will just fold quickly there. If they had a tear of subscapularis, they would have weakness with internal rotation, so I could push them out. But that's an extremely rare diagnosis. It's usually supraspinatus or infraspinatus. Let's talk a moment about supraspinatus. What supraspinatus is thought to do is it initiates, it's the starter motor for shoulder abduction. When we start with our shoulder abduction, we bring the arm out, we're engaging supraspinatus. Once we get out here, we bring in the big motor, deltoid. But this early abduction, this early motion is really done by supraspinatus. And so the classic test you'll find with these patients, I'm going to have Jennifer stand for us, is that it's called a drop arm test. They hold their arm up. I tell them to let go a little, but try to resist me some. And then they get to this point and the arm just flops down. And it's because supraspinatus can't control that last bit of arc. Similarly, they'll have very, very much trouble trying to bring the arm up. But then if the arm is up like this, they're actually quite strong with deltoid. So it's that very early motion. Sometimes if you're not sure if it's a tear or a tendinitis, I'll actually put a little lidocaine in the subacromial space, remove the pain factor, and retest. If it's just a tendinitis, they're suddenly strong because the pain is gone. If it's a full tear, they're not a bit stronger, even taking out the pain. There are a lot of patients who have partial tears. Those are controversial, whether they even need surgery. Sometimes platelet-rich plasma or activity modification can help those patients rather than going for surgery. If it's a complete tear and it's a young enough patient, they should likely go for surgery. Again, the younger patient, it's usually trauma. When you get to sort of my age, there are a lot of people with partial tears, and surgery may not be indicated or even helpful. So one thing to keep in mind is if patients do have a lot of weakness, you'll recall that these rotator cuff muscles, supraspinatus and infraspinatus, they're C5-6 muscles. They're innervated by the C5 and C6 nerve roots. So in your differential diagnosis, you want to keep in mind that it could be a cervical radiculopathy, a pinched nerve in the neck. Some ways you can tease that out is with a rotator cuff tear, for example, external rotation will be weak, but biceps will be strong. If it's radiculopathy, both will be weak. biceps and external rotation. Also supination. Biceps is the great supinator, and the patient, if they have radiculopathy, supination will be weak. If they have a cuff tear, they'll be strong here, and I can't turn the patient. There are some very rare disorders, like something called Parsonage-Turner disorder, which might cause weakness here. I don't think it's really worth getting into those. Those are pretty rare. But at least if you can sort out shoulder from neurologic neck injury, you've actually done quite a service for your patient.